So, thank you. Next, I'm Giovanni Corona, so thank you. So, my talk deals with essentially iatrogenic ED considering a medical point of view, and we will analyze deeply the possible contribution, especially of antihypertensive drugs with specific focus on beta blockers. So I'd like to introduce a very close friend of us, Carlo, who left just a few minutes ago. So Carlo is a little bit older than 45 years old, but he seems 45 years old. Education, university degree, manager of a multinational factory, very happy but stressful for the current situation, never smoker, no alcohol consumption, normal pubertal development, family history positive for hypertension, and 2 months early he was diagnosed essentially hypertension, and his current therapy was based on beta blocker. What is the problems? Difficulties in achieving erection in 40% of cases and in maintaining erection in 60% of cases with mild reduction of sexual desire. And essentially the problem started after the introduction of beta blocker. No reduction of sleep-related erection, masturbation with the same problems, and non-orgasmic problems. Clinical examination, overweight with waist circumference at the lower level of normal range, normal testis volume, and no normal blood pressure on this kind of therapy. Laboratory exam, essentially normal testosterone levels, normal levels of other hormones, as well as glycemia and lipid profile. What do you suggest for Carlo? Maybe change the partner, this could be an option, obviously. Change antihypertensive drugs, PDA5, PG1, penile color Doppler ultrasound. Essentially, the topic is related to the use of beta blockers. So in order to try to better understand this issue, we decided to perform a meta-analysis of the available study, and this is accepted and in press in endocrine, accepted just last week. So this is the first time I'm going to present this data. If we look at the prevalence and the risk of ED in the different kind of population, and we look at the unadjusted odd ratio, indeed, there is 65% increase in the risk of ED. So beta blockers increase the risk of ED. It's true, at least it seems to. When we look again in this kind of data, the odd ratio according to meta-regression analysis, we found that the older age, the higher risk. But the higher prevalence of associated morbidities, including body mass index, so the larger body mass index, the lower the risk. The higher prevalence of arterial hypertension, the lower the risk. And the higher prevalence of history of cardiovascular diseases, the lower the risk. So it means that the risk is higher in less complicated patients. What does it mean? When we look at the fully adjusted odd ratio, indeed there is no risk. So there is no effect of beta blockers, but there is a condition associated with the use of beta blockers, so associated morbidities that can increase the risk. And essentially, these data were confirmed in our population of people seeking medical care for erectile dysfunction. So a large amount of people, around 4,000 people. And we found, indeed, that with the use, even after adjustment for confounding factors, the use of different kind of antihypertensive medication, beta blockers, calcium channel blockers, AT2 receptor blockers, H inhibitors, and diuretics, no risk. So data were not confirmed in a fully adjusted model. What about placebo-controlled RCT? This is the most famous one. So nocebo effect related to the use of beta blockers. 3 groups of patients. The first one, this is just a drug for hypertension. This is a beta blocker for hypertension. This is a beta blocker for hypertension and can cause side effects. And placebo control with sildenafil. And obviously, the prevalence of erectile dysfunction was higher in those people who were informed about the possible related side effect, and no difference in response to sildenafil. And essentially, we found that the use of several antihypertensive medication were associated with different psychological disturbances. What about the placebo-controlled study? This is one of the most famous, published in 1997. So beta blocker, calcium antagonist, thiazide drugs, alpha blockers, and enalapril versus placebo. 24 months, essentially, the use of diuretics were associated with an increased risk of ED. This was not the case with different other kinds of medication. But moving at 2 years, again, no risk. So this is, again, the overall risk of ED related to the use of beta blockers in comparison to placebo or controls. And again, look at this, there is no risk. What we have found, looking at not ED, but the frequencies of coital intercourse were lower in those patients using any kind of beta blockers. And again, this was confirmed in our population. But the problem is that the beta blockers are not only the same drugs. There are several selectivity of beta blockers. In particular, nebivolol, atenolol are more selective. There are no selective beta blockers, so the first wave of beta blockers, such as propranolol or timolol, and there are those drugs which also show an alpha blocker effect. And the most important, so the best for beta-1 selectivity is nebivolol. So this is again is a paper showing the effect of shifting from different other kinds of beta blockers to nebivolol. And as you can see, there was an improvement of erectile function as well as the frequencies of sexual intercourse per month. Essentially, these are data coming from Martinez Salamanca in penile arteries of diabetic subject and normal subject. And as you can see, PDE5 inhibitors can enhance vasodilation induced by nebivolol, so vardenafil, tadalafil, as well as sildenafil. And particularly nebivolol can increase GMP accumulation after the administration of sildenafil, tadalafil, and vardenafil as well. And these data were confirmed when, again, beta-1 selective beta blockers, so metoprolol, was compared to monoxidil. Indeed, also we found there are some data showing that beta blockers can also reduce the production of testosterone, and this can explain, at least partially, the reduction of the frequencies of sexual intercourse. So indeed, when we look at the weekly coital intercourse related to the use of nebivolol in comparison to the other beta blockers, indeed, we did not find any difference. But indeed, we found that erectile function domain score related with the use of nebivolols were significantly higher in comparison to other beta blockers. This is why, because here, if we look at the possible contribution, for sure, obviously they can be explained by the reduction of testosterone, but another important issue is that the combination of beta blocker effect and alpha blocker effect can impair the firing of adrenaline at the central levels, which is essential for sexual function. So essentially, lower impact of beta-1 selective beta blocker. What about other classes of antihypertensive medication? So essentially, central sympatholytic drugs, such as clonidine, are associated with a very, very high risk of ED, especially, again, by blocking noradrenaline firing at central levels. So central sympatholytic drugs have tremendous negative impact on ED. However, there are only very, very few controlled studies, and I have no time to show you the data. What about the other classes, especially valsartan when compared to carvedilol in this case? Again, carvedilol is alpha and beta blockers. This is a double-blind placebo-controlled with crossover. Look at this. Again, this is valsartan, sexual intercourse per week, showing the best effect when compared to carvedilol and as well as placebo. Another issue, so lisinopril versus atenolol, double-blind placebo-controlled with crossover. Similar results, essentially. Look at this. These are data with atenolol. These are data with lisinopril versus placebo. Finally, last study, again, valsartan. Valsartan plus thiazide diuretics, and as well as conventional therapy. Look at this. The introduction of hydrochlorothiazides was associated with, again, a reduction of intercourse per weeks when compared to valsartan alone, as well as obviously conventional therapy. So possible negative effect of thiazides, possible positive effects of AT2 blockers and ACE inhibitors. Accordingly, this is a network meta-analysis published very recently, showed indeed that there is no risk when compared to placebo when all classes of antihypertensive drugs were studied. Obviously, here there are no data related to central sympatholytic drugs. So if we try to summarize the effect, there is obviously negative effect of centrally acting drugs, so clonidine and alpha-methyl-dopa, possible negative effect of thiazides, and as well as potassium sparing, which has essentially an anti-androgenetic effect, neutral effects of calcium channel blockers, possible effect of ACE inhibitors or angiotensin receptor blockers, and especially better effect of nebivolol when compared to not selective beta blockers. These are recommendations coming from the Italian Society of Androgen and Sexual Medicines. We recommend investigating erectile function in all subjects with hypertension, and we suggest against using beta blockers as the first-line therapy in patients with de novo diagnosed arterial hypertension. So my conclusion. Beta blockers, thiazides, and clonidine are frequently associated with AD, but pay attention to the selectivity of beta blockers. Few studies with calcium antagonists, but along with ACE inhibitors, seems to have a neutral effect, possible positive effects of AT2 blockers. And essentially, I'd like to thank all the people who were involved in our study. And as the president of the SSN, I'd like to remind you our educational activities. The school, which is also supported by ISSM, fully booked this year. We launched this new educational activity called EFUS, ESSM Female Ultrasound School, to increase the awareness and the skill related to the use of ultrasound for the evaluation of female sexual dysfunction, and obviously our surgical academy. And I'd like to invite you to join us in Vienna next February. Thank you for your attention.